external cephalic version and reducing the incidence of term breech presentation. Green Top Guideline number 20A, March 2017. Purpose and scope. External cephalic version, or ECV, is the manipulation of the fetus through the maternal abdomen to a cephalic presentation. Introduction and background epidemiology. Breech presentation complicates 3 to 4% of term deliveries and is more common in nulliparous women and in preterm deliveries. Following the publication of the term breech trial, there was a significant decrease in the number of women undergoing vaginal breech birth. External cephalic version, or ECV. How effective is external cephalic version in preventing non-cephalic birth? Women should be informed that the success rate of ECV is approximately 50%. Women should be informed that after an unsuccessful ECV attempt at 36 plus 0 weeks of gestation or later, only a few babies presenting by the breech will spontaneously turn to cephalic presentation. Women should be informed that few babies revert to breech after successful ECV. Women should be informed that a successful ECV reduces the chance of cesarean section. Success rates of external cephalic version, or ECV, vary. Overall success levels are greater for multiparous women, 60%, than for nulliparous women, 40%. Spontaneous version from breech to cephalic is unusual at term and occurs in only 8% of primigravid women after 36 weeks of gestation. Where ECV at term has been unsuccessful, only 3 to 7% of babies will spontaneously turn to cephalic presentation. Spontaneous reversion to breech after a successful ECV is rare, occurring in only 3%. Does external cephalic version affect the outcome of labor? Women should be informed that labor after ECV is associated with a slightly increased rate of cesarean section and instrumental delivery when compared with spontaneous cephalic presentation. Even after successful ECV, women remain at increased risk of cesarean delivery for both obstructed labor and fetal distress. There is also an increased risk of instrumental vaginal delivery. The risk of cesarean delivery may be greater with a shorter ECV to labor interval. Can the success of an external cephalic version attempt be predicted? ECV success can be predicted to some extent, but the use of models to predict success should not be used routinely to determine whether ECV can be attempted. Success rates depend on multiple variables. It is likely that case selection considerably affects success rates. A meta-analysis showed that multiparity, non-engagement of the breech, use of tocolysis, a palpable fetal head, and a maternal weight of less than 65 kilograms were predictors for successful ECV. Other factors, such as posterior placental location, complete breech position, and an amniotic fluid index greater than 10, are also predictors for successful external cephalic version. There are limited data to suggest that estimated fetal weight affects success rates. What methods can be used to improve the success rate of external cephalic version? Use of tocolysis with beta mimetics improves the success rates of ECV. Routine use of regional analgesia or neuraxial blockade is not recommended, but may be considered for a repeat attempt or for women unable to tolerate ECV without analgesia. Beta-mimetic drugs may be administered routinely, reserved for where the uterus is tense, or for where a previous attempt without tocolysis has been unsuccessful. A significant reduction in the incidence of cesarean has been demonstrated with the administration of beta-mimetic drugs where a previous attempt without tocolysis has been unsuccessful. A pragmatic regimen consists of 250 micrograms of salbutamol in 25 milliliters of normal saline, 10 micrograms per milliliters by slow intravenous injection, or 250 micrograms of terbutaline subcutaneously. Beta-mimetics should not be used in women with significant cardiac disease or hypertension and will not be effective in those taking beta blockers. Maternal palpitations, tachycardia, flushing, tremor, and occasional nausea may be experienced. Regional anesthesia requires less force and may reduce failure rates, particularly in conjunction with tocolysis. The effect of regional anesthesia on cesarean section rates, however, is less clear. Some women might be helped by the use of clinical hypnosis prior to ECV. When should external cephalic version be offered? ECV should be offered at term from 37 plus 0 weeks of gestation. In nulliparous women, ECV may be offered from 36 plus 0 weeks of gestation. Gestation at term does not appear to affect success rates. There is no upper gestation limit for when ECV can be offered, but contraindications may be more common. There is no clear benefit to ECV prior to 36 weeks of gestation. In nulliparous women who have a low chance of a spontaneous version, ECV from 36 plus 0 weeks of gestation seems pragmatic. Spontaneous version in multiparous women is more common. There is a paucity of data on intrapartum ECV, but success has been reported. Intrapartum ECV may be considered if informed consent is possible, providing the membranes are intact and no contraindications exist. With an unstable lie, ECV is reasonable in the course of stabilizing induction. There are limited data on this procedure, but potential risks include cord prolapse, transverse lie in labor, and fetal heart rate abnormalities. ECV should only be performed if there is a valid indication for induction. What are the contraindications to external cephalic version? There is no general consensus on the eligibility for or contraindications to ECV. Women should be informed that ECV after one cesarean delivery appears to have no greater risk than with an unscarred uterus. There is limited evidence concerning contraindications for external cephalic version. Only placental abruption, severe preeclampsia, and abnormal fetal Doppler or cardiotocography or CTG are supported by any evidence. ECV is contraindicated where an absolute reason for cesarean section already exists, for example, placenta previa major. It is generally considered to be contraindicated in a multiple pregnancy, except after delivery of a first twin, where there is rhesus isoimmunization, current or recent, less than 1 week vaginal bleeding, abnormal electronic fetal monitoring or EFM, rupture of the membranes, or where the mother declines or is unable to give informed consent. ECV should be performed with additional caution where there is oligohydramnios or hypertension. The role of ECV with a previous cesarean section has been controversial. The largest analysis compared ECVs performed in women with previous cesarean section with ECVs performed in other multiparous women and concluded that ECV is safe and successful in women with one previous cesarean delivery as with other multiparous women. What are the risks of external cephalic version? Women should be counseled that with appropriate precautions, ECV has a very low complication rate. Although case reports of placental abruption and large fetal-maternal hemorrhage exist, complications associated with ECV are very rare. The reported risk of emergency cesarean section within 24 hours is approximately 0.5%, with the indication in over 90% being vaginal bleeding or an abnormal CTG following the procedure. A population-based cohort study comparing breech births where there had been unsuccessful ECV with those where ECV had not been attempted showed a small increase in short-term adverse outcomes after an unsuccessful attempt at ECV. This was irrespective of whether labor was attempted. What measures are appropriate to ensure fetal safety? External cephalic version should be performed where facilities for monitoring and surgical delivery are available. The standard preoperative preparations for cesarean section are not recommended for women undergoing ECV. Following ECV, EFM, or electronic fetal monitoring is recommended. Women undergoing ECV who are D negative should undergo testing for fetal-maternal hemorrhage and be offered anti-D. There is limited evidence to guide practice. No more than 4 attempts are advised for a suggested maximum of 10 minutes overall. Electronic fetal monitoring or EFM prior to the attempt is advised. ECV should be performed where facilities for ultrasound, EFM, and surgical delivery are available. However, fasting, administration of anesthetic pre-medication, or insertion of intravenous access, unless for tocolysis, are not recommended as the need for cesarean delivery is less likely than for women in normal labor. Ultrasound should be used during and after the ECV to confirm a normal fetal heart rate. A transient, less than 3 minutes fetal bradycardia after ECV is common, but should instigate continuous monitoring in a left lateral position and if persistent and not improving after 6 minutes, should prompt preparation for Category 1 cesarean section. Urgent delivery should also be advised following the procedure if there is vaginal bleeding or unexplained abdominal pain or if an abnormal CTG persists. Anti-D immunoglobulin is recommended for women undergoing ECV who are D negative unless the baby is known to be D negative also. A minimum of 500 international units is recommended within 72 hours. Routine screening for fetal-maternal hemorrhage is recommended by the British Committee for Standards in Hematology to assess which D-negative women might benefit from additional anti-D. A strongly positive, for example, more than 30 milliliters, Clay-Hauer should prompt immediate fetal review. Who should perform external cephalic version? ECV should only be performed by a trained practitioner or by a trainee working under direct supervision. How acceptable is external cephalic version to women? Although most women tolerate ECV, they should be informed that ECV can be a painful procedure. External cephalic version is not universally acceptable to women. Barriers include fear of pain and vaginal birth and accounts of others' experiences. Maternal experience of ECV varies enormously. How could the uptake of external cephalic version be increased? The uptake of ECV is best increased by timely identification of the baby presenting by the breech and provision of evidence-based information. In the UK, the views of obstetricians on ECV are generally positive, but there are some negative perceptions among women. Patient acceptance could improve if accurate information on the benefits and risks are given. The greatest impediment to the use of ECV is the non-identification of breech presentation. The proportion of undetected breech presentation at term has been reported in as high as 20.0 to 32.5% of all breech presentations, and these have worse outcomes. The possibility of breech presentation should always be considered at clinical examination, although abdominal palpation has a sensitivity of only 70%. In the absence of routine third trimester ultrasound, particular care should be taken with high-risk groups, for example, where a previous baby has been breeched. Recurrence rate after one breech presentation is 9.9%. Access to a presentation scan after 36 plus 0 weeks of gestation is essential. How can an external cephalic version service be developed and audited? There is no evidence to support any particular service model, although larger institutions may consider a dedicated ECV clinic. What is the role of non-external cephalic version methods? Women may wish to consider the use of moxibustion for breech presentation at 33 to 35 weeks of gestation under the guidance of a trained practitioner. Women should be advised that there is no evidence that postural management alone promotes spontaneous version to cephalic presentation. Moxibustion, a traditional Chinese medicine therapy using moxa made from dried mugwort, has been used from 32 weeks of gestation to promote spontaneous version. It is unclear how moxibustion might promote version, but it is thought to promote fetal activity. Moxibustion, when combined with acupuncture, may result in fewer births by cesarean section. There is insufficient evidence to support the use of postural management for breech presentation.